No, I think we need to wait a couple of minutes.
Okay. Yeah, we'll just keep it.
I'm trying to ping her. Just wait a minute. I've pinged her. Not sure if she's available now, but yeah, you can proceed, I think.
All right, thanks, Jen. Yeah, we'll see if Jiwon joins in. So yeah, I think we are 3 minutes into the call and the recording has started. Okay, so we have Jason today with us, who will be sharing with us on the topic of framing the research question. This is part of the series for the OHDSI APAC-VALUE study. And over to Jason. Thank you.
Okay. Good morning, everyone. Let me share my screen. Can you guys see my screen?
Yes, we can see.
Okay, thanks. Okay, let me get started. Okay, hello everyone. My name is Jason Shi, and today it's my pleasure to share the conceptual blueprint of our APAC value research projects. And the theme for today is framing the research question. And as you may know that when we do the multi-center cross-national real-world data study, asking the right question is much important than simply running the number, the data. And how do we translate the complex intervention, like a policy, health policy, and shift into the clinical data analysis is what we want to discuss today. And asking the question is the soul to what we are going to do the study. And we want to use this APAC collaborative study to become an example and to discuss about how to framing the research question for our future study. And before we get into the presentation, just allow me to briefly introduce myself a little bit. I'm currently the president of OHDSI Taiwan Society and also the professor in Taipei Medical University in Taiwan. And my research interest is health data science and clinical data analysis. And my team has long been focused on using the real-world data to address the critical unresolved challenges in clinical issues like drug efficacy and safety issues, and also healthcare management. And this is also why we are so deeply invested in the this study, the collaborative study about the drug safety evaluation topic. And just based on Nico's presentation last time in our APAC community call, let's take a look at the topic about our research. This is a starting point. The name of the topic is the APAC-VALUE study, a global characterization study of fabric utilization and exposure among both men and women of childbearing age. And as international drug utilization regulatory agency has continuously upgrades their safety warning about the various policies. And the aim of this study is to map up these utilization trends and the population categorizations and among different countries. And how do these high-level regulatory safety warnings actually translate into the real-world clinical practice across different regions? And why this fabric study is going to be a critical study for us to do the research. And because fabric is it's like a double-edged sword. On the left side, it remains and because fabric is a highly effective first-line treatment for the generalized epilepsy, and also its clinical efficacy is virtually unmatched. However, the right-hand side is kind of safety issues about the teratogenicity of the pregnant women, and exposure in utero during pregnancy is associated with up to 10% of risk of major congenital malformation in the offspring. And this presents a painful kind of dilemma, clinical dilemma. How do we balance the mother's critical needs for zero control and against the long-term devastating health risks to the next generation? And the situation is becoming more and more complicated recently because historically the clinical consensus was very simple, which is protect the pregnant mother and the baby will be fine. However, recent medical evidence has told us that there are some findings that are groundbreaking, and it revealed the paternal exposure to fabric within 3 months prior to conception is associated with significantly increasing risk of neurodevelopmental disorders such as autism and ADHD in the offspring. And this is the revolutionary clinical signal. And because it tells us that fabric safety is no longer just a woman's issue, and it has officially extended to the young men who are planning to become fathers. And we must now expand our research lens from traditionally maternal protection to preconception partner risk, father's risk. And this brings us to the perfect intersection of clinical science and public health policy. When clinical research uncovers an unmet clinical safety needs and the scientific evidence accumulates, policymakers must act, translating this science into the public health action. It's like this evidence-informed policy cycle. We start from the top, the scientific evidence, and move to the problem identification, problem definition, and policy design. We may have some policy and choose select the best policy, appropriate policy, and to do the policy implementation. And throughout the application of policy, we needed to do the monitoring of the policy, and eventually to have an evaluation of the outcome. We have some KPI, and then to see what is impact of the policy exactly, and also specification, and go back to we may have a next generation, new information about the evidence. So this kind of a policy loop. Okay, so in the evidence-informed policy cycle, the study we are launched today is about more like the outcome evaluation, the later stage. Okay, we are just using real-world data to evaluate whether these policy interventions are actually delivering the protective outcomes the policy promised. Okay? The government promised. And to systematically evaluate how different governments across the global have reacted to involved safety issue, safety signal, and we want to use the classic 5W and 1H management framework to do to discuss about the questions, usage questions throughout the whole process of the stages of the policy cycle. We can think about any questions we can is valuable for us to do the research, and we can use the 5W and the 1H to have a comprehensive thinking about that. And we want to talk about the first one is why. Okay, what was for this study? What was the driving force behind this kind of guidance shift? Okay, and who? The next one is about who. Okay, who is expanding target population, and we are trying to protect. Okay, not only mother but also father maybe. Okay, and next one is what. For example, what is the actual clinical restriction imposed in rates? Okay, and then where? Okay, where are these policies being implemented across APAC countries, and how intense, like the level of the force, are they in different countries? And this is about where. Okay, so this is an interesting point because our study is multinational collaborations. So it's cross-national study rather than just based on the single country or single database. So international comparison will be the interesting part. And then now, since we have different data source partners and represents, we have the data from different countries, and then we can do the collaborations and to see what's the varieties about the results among different countries. Okay, and the next is when. Okay, what is the timeline of this stage right the policy shock? Okay, because the governments in different countries they carry out implement the policy regulations about the safety warning of the drug in different timing. Okay, so the timing is also an important point we need to to the analysis in our study. And then finally, it's about the how. Okay, how are this policy being administrative enforced in real world clinical systems in different countries? So first, let's talk about the why. Okay, if you look at this slide, our historical mindset was highly linear. Okay, kind of pregnant mother takes the medicine and the drug is exposed to fetus in utero, and that will lead to the congenital malformations. But the new evidence since around 2024, this cultural change has undergone a massive paradigm shift. A partner preconception exposure, like a father before the preconception, they have the exposure about the favorite medication, may alter sperm quality or epigenetic factors, and that will lead to neurodevelopmental risk in the next generation. So this is the fundamental and also the scientific engine driving the global shift in clinical guidance. And we are moving the starting points of our safety warnings backward, shifting from maternal pregnancy management to paternal preconception management. The next question is who? Okay, the regulatory shield is expanding. Okay, and originally the protective shield was held exclusively in front of pregnant women and their unborn fetuses, focusing on the maternal protection. And today, we must think about the shift to the right, expanding to cover males of childbearing potential who have reproductive plans and addressing the partner risk exposure, like a father's exposure. Okay? And particularly, this means that when the neurologist treats the young male patients, like with epilepsy, they must now conduct family planning consultations and the risk communication before writing the appropriate prescription. Okay. Next will be the what. Okay. This is about the shift in Fabric clinical positioning. In like this treatment hierarchy, Fabric was once considered a preferred first-line treatment or the highly favorable alternative drug for epilepsy. However, as more and more evidence showed us the risk about that, and there's a regulatory restriction hit, and its clinical standing was pushed all the way down to the bottom of the pyramid, like the last resort. Okay, and also the clinical guidelines now tell us that on this, all other anti-seizure medications have failed or completely intolerable. Clinicians can absolutely not prescribe favorites, and it has transformed from the clinical first choice to the reluctant last resort. Next is about the where. And I think this is the most interesting point. And how the regulatory was implemented varies widely across different countries. And so this is about where. Okay? And like in APAC region, we have a high policy heterogeneity. For example, some countries have implement highly um, aggressive mandatory pregnancy prevention program, and but the others like have the moderate intervention, and we also have like a limit taking limit. Some countries take limit action, or even some countries they don't have any actions. Okay, to do that. And the heterogeneity is precisely where the core scientific value of our cross-national study lies. And how do these different levels of policy intensity affect the real-world impacts, like the describing or substitutional patterns of fabrics? And the next is about when. Um, this is the major methodological challenge in our study design about the when, because you can see the policy shock didn't happen in all at once, and they are staggered. We have two waves. One is about mothers. Okay, wave one, which focuses on the maternal exposure warning signs, and around 2010 to 2020, because the policy, the regulation changed along with the new evidence dynamically, and the government may have a different level and enforce, okay, to policies, okay, different type of policy to manage this kind of medication utilization. So from 2010 to 2020, for the wave one, okay, across all countries in the world, okay, and the wave number two, which addresses the newer paternal per conception risk for the father, okay, and also start from the Singapore in 2023. I mean, in Asia, in APAC region, Singapore in 2023, Japan and South Korea in 2024, and Taiwan in 2025. This is based on the previously review made by Nico Pratt, okay, similar like this. And because of this staggered chronological shock, it is impossible to let us to use a single fixed calendar year as the pre and post policy index day for all countries. So we needed to implement a relative time cohort research design. Okay, so later on we need to talk about this. Okay, about research design for our future cross-national study. And the last one is how. Okay, um, the absolutely core of policy implementation is how. How do governments actually enforce these rules, the policies in doctors' daily workflow? Okay, and then we compared. We can at least have three type of models for the policy implementation. Like some countries, they use like a prevent, okay, a highly stringent mandatory program where and the clinicians must like physically complete checklist and hold face-to-face consultations and sign the annual risk acknowledgement forms. And this acts as a physical gatekeeper. Okay, and the other one the other countries, they use the more powerful nationwide, like a DUR, the Drug Utilization Review electronic system. And at the moment of physician try to choose prescribe favorites, this medication, a digital pop-up block instantly locked in the screen, and forcing the doctor to reconsider and select the alternative medications. And the last one is the label and the package insert revision only. Okay, so our study will evaluate the real-world gap between this active digital restrictions and the passive risk communication, which enforcement mechanism actually succeed in alternate prescription behavior. Okay? Because this is why before we doing the research, getting involved into the data processing and analysis, last time Nico led us to do the review of guideline or regulations in different countries, and then now we are going to think about any research questions we need to discuss. Okay, because different type of policy implementation way may have a different impact. So that would be maybe the reason if we have we got the findings with various of our results among countries, and we can use this to think about any possible reasons, okay, about that. And so now so what is the underlying research logic for our study? Okay, so we are moving from the policy execution to retrospective analytical evaluation, and many big data study fall into the trap of showmanship, and just simply providing they can process millions of records and draw the beautiful statistics figures. But we need to think about the big data analytics and the figures are merely expression tools. And the true goal of our research is to answer the critical question, which is the so what. Okay, once these policies were implemented, did we actually protect patients, and then did we succeed in reducing congenital anomalies and neurodevelopmental risk in the real world? So we have in our study we have question number 1, which is the basic one about this is from the macro level view. Okay? Did the policy effectively deter the overall or have an impact to the overall drug utilization? And here we are measuring the macro population shift. So our tool of choice is longitudinal trend using this kind of that's curve, okay, stratified by gender, okay, and what we hope to observe is a clear inflection points and like a downward trends following the safety warnings or regulations changing point for both males and the females. Okay, but does the real world actually mirror this ideal scenario or not? We don't know right now, and that is the result we want to make for the future by using the data. Okay? And what are the real-world policy implications for research number one? I think from different point of view, different type of population, or we may have a different expectation. Okay, for policymakers, we are assessing the policy penetration. Okay, in that country. Okay, like does passive risk communication actually work, or any other type of safety warning or actions work or not? Okay, or do we absolutely need hard digital barriers, like some countries use the DUR system or others? Okay, but for the epidemiologists, some we are looking at international spillover. Okay, for example, when some countries they issued this major alert, safety warning in the beginning, and then did clinicians in the other countries reduce their favorite prescription even before their own local governments issued the mandate, the regulations. Okay, and detecting this temporal lead or lag across borders is key to evaluating national scientific influences. And then talk about the question number two, which is the micro behavioral model. Where did those clinicians and the patient actually go? Okay, and where did they shift to? Okay, so this is a micro level behavioral model, and we will employ use the sunburst plot to map and track individual treatment pathways before and after the policy shocks. Okay, and in this sunburst plots, the rings, the inner ring, represent the broader different type of drug classes used in the beginning, early stage, and then the outer ring represent the specific medication pathways. Maybe we'll have different label, different rings, okay, and to show the results. And then we want to see with high precision, did the female patients safety translation to from the favorite to the other treatment like lamotrigine or like a liver uh, levity reactant or other medications, and did they switch to other high-risk medication or not, or did they just abruptly discontinue the therapy altogether or not? Okay, so this is how the prescription pattern can the result can tell us about that. Okay, and this is why is this micro level so critical? Because it directly impacts the patient outcomes. In an ideal clinical scenario, we want to see safe, gradual switching or cross tapering of the medication. Okay, and physicians slowly taper down the dose or utilization rates will be a better way to have the change in the prescription pattern. Okay, and that will be can help us to maintain the seizure control throughout. Okay, and the dangerous alternative way is like a right hand side abrupt cessation of the medication. Okay, and driven by the fear of the new safety warnings, maybe the clinician or patient stops operates immediately, and this creates a critical risk window of relapse before the new drug reach therapeutic concentration. Okay, and potentially that would be trigger the status epilepticus, okay, severe epilepsy syndrome, and maybe emergency department visits, and also the hospitalizations. And only by the mapping this reward pathway can let us to ensure the patient safety during the regulatory transitions. And therefore, before we start to do the research, to do the data analysis by using the data and the softwares, we needed to have the analytical solve. And there are two questions in our study, basic questions, not related to outcome, not yet, okay, because we want to focus on the descriptive analysis first, and then we consider outcome and to think about the analytical analysis with test of hypothesis. Okay, so the first two questions is question one is kind of, as I mentioned, the macro perspective, and capture the population level time series changes by using longitudinal trends figures. And question number two handles the micro perspective and use the individual level treatment transition by using the sunburst plots. And we must remember that big data analysis is a method, and the statistical figure charts are the expression only. But the answer these two critical questions is the soul of the cross-national study. Okay, and at the bottom of this slide shows that the clarity in the question, rigor in the method, and impact in the answer. So in summary, in our study, we can bridge a massive critical gap in the healthcare. So like on the left-hand side, I mean here left-hand side gap, left side of the gap is the paper-based notice made by the government, like official guidance issued by the regulatory bodies. But the right-hand side, we have clinical and maybe have a clinical anxiety, and the real-world confusion and uncertainty experienced by physician at the point of healthcare care. And to close the behind spots, we may have like a analytical three arrows we need to discuss. The first number one is that really? Okay, is the policy truly effective or not? And we will establish the real world evidence to choose, like question number one. Using question number one, the result of question number one can answer. Okay, and then the second one is root cause, and it's about the why do these patterns occur? Why does this happen? For example, if we find some result from some countries, they may have very big significant changing of the drug utilization before and after the regulations, and what is the reason about that in those countries? And what if we also find some result from other countries? There's no different before and after the regulations, or even the result shows totally different with what we expect from our expectations. Okay, so what is the reason about that? Okay, so we need to think about, have a discussion, further discussion about that. So this is why does this happen, and then where does the problem lies? Okay, the last one is so what? Okay, what are the real world implications, and how should we respond? So what are the clinical and how should we optimize the further safety policies? Okay, so every parameters we set in the data is to close behind blind spots and clear the question, define the logic, and then the data will lead us to the truth. And to do this study, this cross-national APAC study successfully, we must align our study parameters, and we also need to have a further discussion about some big issues. At least 3 issues we need to discuss later on. Like the first one, ensure the clean target cohort. Okay, because like we must do we need to exclude the psychiatric indications like bipolar disorders or migraine, okay, to prevent confoundings, okay, and only focus on the like epilepsy population, okay, or maybe others cancers, any type of cancers, or any other situation we need to for the population point we need to think about that, like exclusion criteria, using the exclusion criteria. And the second is expand our demographic. Okay, it's about the demographic based on the UK or some countries in Europe, because for the men, protection. Usually they use the 55 years, okay, as a maximum, the oldest age for doing the research. So how about using that and to collect the data, the case, and then for both men and female, male and female, and then to do the study later on. Okay, so this is about the aging. Okay, the age we can set up, okay, for our study. Okay, and the third one is about the overlap windows. Okay, like about the shift of medication prescription. Okay, so as I mentioned, we can change. We have a physician can change the medications step by step, and also they can just discontinue the favorite medication and to change to others. Okay, immediately. Okay, so what is the overlap window will be appropriate, and then we can set up for our research study, and then we can have a defined definition about that later. Okay. So achieving consensus on these parameters across all APAC sites is absolutely vital, critical to ensure the cross-border comparability and the scientific rigor. And this is our path to consensus. So finally, we must close the policy loop, and the ultimate destination of this cross-national research is not just another publication, like another paper in the journal, but our vision is to transform this robust cross-national real-world evidence into the actionable policy recommendations. So we may aim to synthesize our findings into the Asia Pacific medication safety policy white papers, okay? And also to distribute this white paper to serve as the powerful data-driven tool evidence to empower regional regulators and healthcare leaders to optimize and redefine the medication safety policies in the future, okay? And then making the clinical decisions safer for patients across the globe. So thank you very much for your listening. And this is the design framework about how to think about the research questions and for our study. And we expect that we can work together in the future. And then if you have any comments or any suggestions for research design or like parameters selection, welcome to contact with us. You can contact with Nico or me by email in the future. And I thank you very much for your time and attention. Thanks. That's it.
Thank you, Jason. I think it was very comprehensively shared. Did the whole life cycle of framing the question all the way to asking and creating that policy. All right, I think we've got a question from Sarah. Sarah, your hand is up.
I think she raised her hand by accident.
Okay. Hey, Juan, good to see you. Yeah.
Yeah. Sorry, I was late. I was kind of late today's meeting. I was in lunch, so sorry for that. And Jason, thank you for preparing whole this overall of our so far our output and work. And I have several questions. Since I mentioned about the sunburst plus sunburst plot
Yeah.
last month, and today I saw another sunburst plot in Jason's presentation. And the reason why we are kept mentioning about that is that figure is one of the the main flower of the characterization. But I kind of wonder is in our study, we are just targeting the bob rate, right? So what I was thinking is, does the bob rate for our intended population have a meaningful treatment pathway at all? Because we are just targeting one bob rate, right? So that was my question. And one more thing is, while we have reviewed the general policy guidelines around APAC regions, but I also kind of came up that once we clearly define our target population, we should systematically examine the disease specific treatment guidelines too, because since we want to see a treatment pathway, then there must be something the guidelines or the clinicians are suggesting how to treat the patients, right? So I think after we're done with the overall protocol, but we also need to look through the treatment guidelines too. That was my suggestion. Yeah.
Yeah, thanks, Juwon. For the first question you mentioned about do we only focus on the evaporates or also consider the other type of alternative medication for epilepsy?
Yeah.
For sure, because for the either question 1 or question 2, question 1 using the like a curve longitudinal trends of a medication use, we can also focus on not only just the evaporate, maybe there is a change of evaporate, but also the other type of medication also change the prescription rates. And also some bust plots, we can also think about what kind of medication be preferred to use for the epilepsy before and in the middle and after the policy. In the middle means changing region, during the implementation of the policy. Okay, so we can also do this kind of result, and then to show the difference between among countries in APAC. Yeah. For your second question is about the treatment guideline. Of course, we need to read treatment guideline in different countries in very detail, and then to see if the results made by our data follow the treatment guideline or totally different. Okay, so and that of course we expect that the result shows like a decline of the prescription of the valproate following right after the safety issues, but we may not we cannot assume that the result may look like what we expectations. So so that's why doesn't matter about the results. We need to just show the real world evidence, and then to compare to the treatment guideline, and then to probably there are different level of treatment guideline related to this issue in different countries, and this is the point. We can also make recommendations based on our evidence, and then to initiate some recommendations for the guideline medication modifications. Yeah. Thanks,
Thank you.
Jingwo.
Yeah, thank you. So our target population is the patient with epilepsy and got a prescription of valproate, right?
Yeah, yeah.
Just not. So we are just targeting. We are so targeting. Are we? So we are targeting the patient with epilepsy, or are we targeting the patient with epilepsy who got a prescription of the valproate? So since if you want, like, my question is, if we want to see a treatment pathway, then like it kind of gives a conflict, because we like if there, so is there any like transition from valproate to another drug? Is that that's my question.
Oh, one thing is about the population. I think it's better to define the population simple as better. Yeah, like we only focus on the epilepsy, and then only focus on the male and the female with childbirth age, and also just like the clinical trial, we let our population very clear and without any confoundings, like comorbidities like this, and then your suggestion is about the treatment pathway, about the yeah. So how the drug was changing, like from the beginning, like some patients they have a long-term used valproate, and what about the next alternative medication? Okay, is commonly be used for this medication. Yeah, this is about the detailed study about. I'm not sure if we can use the Sambas plot to show this very detailed situations, but overall, because some plot we can show like the prescription rate changing about the different type of medications, and then if we want to base on this and go further and to classify the patient, like start from the favorite use and then to the other medications. We can also do this kind of a study and then to show the result for that. Depends on Nico's arrangement, because this is a cross-national study, so we can start from the simple one and to make sure that we have a basic result first, and then we can move forward to the advanced. And also outcome is important. So because governments and and others also want to see the outcome for after the regulation, okay, to see if the policy matters or not. Okay, so we can. But that is another questions.
Another scope of the Thanks, Jason. It really gives me a real clear picture of the research now. Thank you.
Thank you. Lukesh?
Yeah, Jason, I had a question more on the data linkage, because we do see a family effect here, right? The mother, the child transmission, and the father, the child, and then there's a family effect as well they're studying. How are you planning to handle the data linkage in the EHR, given that you need the family unit together?
Oh, unfortunately, family relationship is not easy to be accessed in many countries. Yeah, so we in the beginning we don't expect to use the family data to do that, and of course if some countries some database they have this kind of family linkages information, and we also encourage the researchers to do that and then to see what exactly the results, okay, and what is the impact for that, and also after the regulation is this kind of the incident events decreased after the policy made changing or not. Yeah, so this is very unique, very helpful, beneficial information for us to see if we have the family linked data, we can do that.
Yes. Because in Singapore, we do have the Espresso cohort, which is a preconception cohort. It recruited mothers during preconception. And we've been following the mother and child for about 10 years now. And we also got paternal data collected at the preconception and pregnancy. So I'm thinking how that could potentially help this project to show that family effect, because it's a very nice cohort. We can use the preconception cohort. But happy to chat further.
Yeah, wonderful.
Yeah, thanks. Yeah.
Thanks.
Any other questions?
Kish, what was the cohort's name that you mentioned about the mother and the child data cohort? It's like Espresso? That's what you said.
Espresso. Yeah. I'll put the link to the
yeah, please. Thank you.
Study.
Because I'm very, very much interested in maternal and child data. So that will be very helpful.
Okay. I don't have a link to the chat, but you can Google for Gusto Data Vault. You will see a Espresso cohort there. So that's the preconception cohort. Yeah.
Did you just message at our channel here?
Somehow I'm not able to access the chat here. Yeah.
Okay.
Yeah. But yeah, I'll share with you the details. Yeah.
Thank you, Mukesh.
Yeah.
Oh, thanks, Arwin. Arwin sent me
Okay, great.
the link. Yeah.
No problems, Yuan.
Thank you. So our time's up.
Yeah, that's all. Yeah. All right. Right then. Thanks so much, everyone. I think it was a very fruitful session. We'll follow up in the next call at the community session itself. All right. Thank you.
Thank you, everyone. Bye-bye.
Ciao.
Ciao.
Thank you.